Welcome everyone to the audio and video podcast from the Cleft Palate Craniofacial Journal. I'm Pat Chibbaro. I'm the multimedia specialist and really happy to be with you today. And the paper that I wanted to highlight, which you can find online first, I think it came out about the middle of March 14th, which is Feeding Management and Palate Repair Timing in Infants with Cleft Palate with and without Pierre-Robin sequence, a multi-site study. And this is truly a multi-site study. I have three of the authors with me today. I'm really excited to have Jessica Williams from Phoenix Children's Hospital, Kari Lean, did I say it correctly? Yay! From the University of Utah. And then Greg Allen from Children's Hospital of Colorado, and they are here and produce this paper on behalf of the Cleft Outcomes Research Network (CORNET) Consortium, which I didn't know anything about, honestly, and I've learned a lot. And I think I'm really happy that part of what we can do with this recording is to let people know about this, about your work, because there's so much. In fact, I just saw for the current journal, the May 2024, there's a paper from your group about palate repair and the outcomes across many different centers. And so thank you all for being here. And wanted to start first, just back to the CORNET Consortium, the project. Maybe Kari, if you can explain to the listeners what that is about, because it looks like it's a huge undertaking, but it produces so much information.
Absolutely. So I am the postdoc for the CORNET study. Dr. Kathy Chapman at the University of Utah is the principal investigator for that study. And there are several speech pathologists and surgeons who are co-investigators. So the CORNET study is an R01 grant that's received funding from NIDCR, and the primary goal of the study is to look at speech and surgical outcomes at age 3 in children with cleft palate. So it's a comparative effectiveness study, and so it's comparing IVVP surgery with furlough Z-plasty. And so the main research question is to see which children, depending on which surgery type they had, have better hypernasality outcomes at age 3. And so because of that, we've been following these children longitudinally. They're enrolled before they have palate surgery, and then their final outcome, their speech outcome, is collected at age 3. And so there's 17 different sites and cleft palate teams around the United States who are participating in this study. So the surgeons are participating, the speech pathologists have been trained to collect the speech outcomes in a standard way. And so as we are following these children longitudinally, there's also some secondary and tertiary aims, as well as ancillary studies that are being conducted with the longitudinal data we're collecting on this cohort. So there's over 1,200 children enrolled in the cohort across the country who are being followed until age 3. And this study was one of the ancillary studies that was proposed by Jessica and myself. So we wrote a proposal and contacted the lead investigators of the study to express interest that we wanted to look specifically at feeding in children with Pierre-Robin sequence. And I'll let Jessica talk a little bit more about the specific study, but if other investigators from the cleft palate teams who are participating in CORNET are interested in pursuing ancillary research projects, contacting Kathy Chapman to learn more about that process would be a great place to start.
I wanted to just say, I realized when I did the intro that I left out 2 of the authors of this paper, and wanted to apologize and mention that also Dr. Richard Kirshner and Dr. Kathy Chapman are 2 of the authors on this paper. So let's go, Jessica, to, as I like to ask all the authors of papers, is why did you want to look at this particular area? And I know you're very passionate about it because we just came back from the ACPA meeting where you presented a lot about this whole area. So give us a little insight into that, and maybe a bit of an overview of the study.
Sure. Yeah. Thank you. Kari and I used to work together for a handful of years clinically, and we would care for these kids with Puroband sequence. And it sometimes feels like when you provide feeding services or feeding therapy intervention to kids with cleft palate, you have these handful of kids who are non-syndromic, non-Puroband sequence. And if you can kind of get them set up with the right feeding equipment, flow rate, they do fine, right? They do really great. They don't need a lot of management. But then you have these kids with Puroband sequence, and they can be very challenging to manage and really require a multidisciplinary approach, which was why it was so great to have Greg and Richard on the paper as surgeons, as an airway specialist, to really give their input on this. Kari and I were coming at this from, a feeding standpoint. Some of these kids would come to us in clinic. They were born, had very clear airway issues, were immediately admitted and maybe underwent some sort of intervention. But there were cases where kids didn't have any airway intervention, and Kari or I would be the ones who would have to go back to the surgeon and be like, hey, this kid is not feeding well. We think airway is impacting. We really think there needs to be further workup. So that's kind of what led Kari and I to want to look at this. And it felt like a really great opportunity to look at what people are doing nationally to help manage these kids with Puroband sequence by using this Cornet data. So I think our questions really snowballed. So how I like to conceptualize this paper is we wanted to know, how are feeding services being delivered to kids with cleft palate with and without Puroband sequence? That was like our first question. Who's getting a feeding tube? Who's using milk fortification? Who is going to feeding therapy? Just understanding that piece. And that snowballed into, well, for the kids with Puroband sequence, how is the airway being managed? And then that snowballed into, does any of this impact timing of palate repair? Like, is there a difference between kids with and without Puroband sequence and when they're getting their palate repaired? And we did find that kids with Puroband sequence are having palate repair significantly later than their peers without Puroband sequence, which we know has big speech implications. So then our last question that we answer in this paper is like, what are these factors when we stick all these kids back together in a group and build a model? What is causing delayed palate repair? And one thing that I think we did that was really unique was we put in the feeding variables, we put in the airway variables, we tried to look at everything. And ultimately it came down to kids who have Puroband sequence were more likely to have delayed palate repair. Kids of Hispanic ethnicity more likely, and kids who have a history of poor growth. So I think those were some really interesting findings to guide future research and intervention research of how do we target these three groups to help more timely palate repair.
So, when I was reading the paper, having been the nurse practitioner on a team for over 30 years, and I was thinking, what was our criteria? And it was very individual, and it was sort of all over the map. And one of the things I was thinking, and I wonder, Greg, as a surgeon, what your thoughts are. I mean, kids would come, talking about Roband and poor growth. We had kids that would be transferred to us from community hospitals, from other places that didn't have cleft teams. Sometimes the kids were intubated or they were trached, or, and I guess the question is, as a surgeon, Greg, what are your thoughts about, when you get these kids presented to you? I guess one of the things I think is, well, what could I have done, or what could we have done? And I used to talk to my surgeon about this a lot. Like, what can we do to prevent this? Kids are coming to us with Roband when they're 2 weeks old, 3 weeks, because nobody's at these other places before they transfer them are able to, to deal with them or know how to manage them. So, Greg, I was wondering what you were thinking. I've had lots of conversations with my surgeons about this over the years. I was just wondering what your thoughts are.
Yeah, I think the first thing is just recognition of the problem. Many times the patients are diagnosed with just a cleft palate, and people have not really recognized that the patient has micrognathia or upper airway obstruction. And so I think the first issue is just recognizing what the primary problem is. Most of us have realized, during our careers that the feeding issues in children with Robin sequence, it's not really a feeding issue as much as it is an airway issue. And the way I talk to parents about it is, their baby is smart. Their baby knows that if they're having trouble with breathing, they're not going to feed well. And so the baby is protecting their airway. And really the first thing that goes is feeding, because feeding is such a labor-intensive, concentration-intensive thing for that newborn, is that if they start to feed and they realize they're not, they're feeling short of breath, the first thing they're going to do is stop feeding.
Right.
And so recognition of the primary problem, I think, is what is critical. In these birth hospitals, recognizing that the problem is actually an airway problem, not necessarily a cleft problem initially.
Yeah, I agree. Yeah, I agree. It's that choosing breathing. I always, would say when I go into the NICU, they're choosing breathing over eating, and these as you said, these little babies are smart. And I guess for me and for us, as members of this organization and, the kind of work that you're doing, just really shows me that we just need to keep pushing this information out to all these birth hospitals, which I think is a big challenge, because then I feel that the more we can do that and educate, would we have less problems on the other end? Would we be able to get these kids to the OR sooner? Would they have less growth problems? So many things came up as I was reading this, and I'm sure what people who have been on teams for a while are reading this, they're sort of going through what is it that they're doing and what can we do differently. What I came out of this was, I don't think I was surprised at any of the findings, and maybe we can talk about that next. I wasn't surprised by them. It just made me feel like, what can we do, to make it, from the get-go, what can we do to help with this? So I wonder if, and maybe Jessica, if you or whoever wants to give us a bit of an overview about what you did and what you found. And I also would love to know from any of you, was there anything that was surprising, or did you pretty much expect what you found?
Yeah, I'll go first, and then would love to hear from both Greg and Kari. I think, in general, we found that all of the kids with Pierrot-Band sequence were utilizing feeding interventions at a significantly higher rate than the kids who without Pierrot-Band sequence. I think one thing that really struck me is that it is okay, and I think this is part of our education piece to families, that their infant uses enteral feeding, tube feeding to support their growth while the airway is being managed, and then can work on the oral feeding. Like, I think that's such an important piece. And sometimes I think as providers, we want to be like, no, we're going to intervene. We're not going to use, supplementary feedings through a tube. Like, we got it. But these kids might actually really benefit from it to have good growth, to get through these major surgeries if they're like having something like mandibular distraction, to support that. So I think that for me is something I've kind of thought a lot about, and like how I shift and educate families. Honestly, the most interesting finding to me was a very small finding of our paper. In previous literature, they'd estimated that milk fortification or increasing the caloric density of milk was utilized at about 25%. And we found it was like above 50% for our kids with Pierrot-Band sequence, and also high for our kids without Pierrot-Band sequence. So I think we're seeing an increased use in increasing the caloric density as an intervention for all kids with cleft palate, which is an interesting finding when we look at it nationally. So again, a small finding, but one I was like, that is really interesting. So I'm curious what Greg and Kari think too.
But Jessica, I think we at the meeting, when we're at the ACPA meeting, I found that there was a lot. I found several people talking about it, either on the podium or at happy hour, talking about how we just really so closely need to monitor these kids, maybe even more closely than we have in the past. And I agree with the milk fortification, seeing that's at an increased number. I think it's also really interesting, the whole idea of balancing enteral feeding with oral feeding, and when do you introduce that? And I think that is one of those issues, that when to introduce the oral it's so sort of team dependent. Who has a say in it? Is it the ENT, surgeon, SLP? Who, makes that decision about when to move forward, and how do you evaluate them before you decide to move forward with the oral feeding? And I feel like that's sort of a stopgap, I think, in trying to progress, as you said, to accepting the combination of enteral and oral. So I was glad to see that. I think there's more conversation about that needs to happen to push that forward. Kari, what other thoughts from you?
I also wasn't surprised by this finding, but when looking at the predictors of delayed palate repair, poor growth was one of the significant predictors of the children who were going to have timely palate repair versus palate repair after 12 months of age. And so as speech language pathologist, Jessica and I care so much about the speech outcomes in these children. And so we want to have timely palate repair so it supports early speech and language development. And so identifying that those children with poor growth are at risk for delayed palate repair, which will likely have downstream effects on speech and language development, tells me that we need to dig more into what the predictors of poor growth are in this population so that we can mitigate that even faster and more efficiently for these children to try to get them to a timely palate repair if feasible.
And Greg, this is where, I think about the timing of palate repair, that conversation that has to be had, and it's ongoing between the people that are involved in feeding and speech and the surgeon, because you have the concern, and it's always, and what I'm saying here, you worry about speech, and we, the surgeons, and I remember having many conversations with my feeding team about, there's the concern about growth, but there's also the concern about airway. If you close a palate on a child with Robin, at what is the right time? Greg, I'm sure you have this conversation a lot, and as an ENT, you're just so enmeshed in it, and so I wonder, do you think there's and do you have a protocol? So for example, for children's, in Colorado, does your team, who makes the decision about when the palate should be closed, and is there, what kind of conversation goes on?
So it is the primary surgeon who makes the decision on timing of palate repair, but it's very clear from the literature, as well as working with my own speech language pathologist, that early palate repair is much better for speech language outcomes. So by them hammering on me for years and years, they have convinced me that trying to get the palate closed as early as possible is very key. The thing that balances that is the nutritional status. And so I think the poor feeding outcome from this study highlights the fact that even though we may not have clear agreement from surgeons on how these airway issues are managed, there is clear agreement that good nutrition is necessary for healing of a palate repair.
Right.
The worst possible outcome is trying to palate repair early and doing that on a baby who is not in good shape nutritionally, and then having a dehiscence or a fistula. Possibly, one of the contributing factors would be the nutritional status of the baby. So even though we may not have clear agreement on how we manage the airway, there is clear agreement that we need to try and boost the nutritional status, whether that's enteral feedings or fortification of the formula, trying to maximize the nutritional status as early as possible is going to allow us, regardless of how the airway is managed, is going to allow us to repair that palate sooner. And so although these results were not surprising, I think they do point to the critical nature of nutrition and feeding very early on and trying to get the nutritional status as good as possible. Even if we don't agree on how to manage the airway, we can agree that the nutritional status and early palate repair are critical.
Greg, I want to add to
Absolutely.
that. I was having like a really interesting conversation with someone just this last week who was like, her kid who doesn't have a cleft, she's like, they had difficulty growing and the pediatrician just wasn't that worried. Why are we so worried about these kids with cleft palate? And my answer was, your kid didn't have to undergo a major surgery in the first year of life that they have to recover from, probably will lose weight after for a while and then come back. So I do think it's different for these kids who are undergoing surgery versus kids who don't have a cleft and maybe kind of struggle. And the pediatrician says, they'll outgrow it, they'll come around, because maybe they do. But I do think these kids, you're right, like the nutrition status is important because they are undergoing surgery and need to recover.
Absolutely. one of the things that, just in terms of timing, I saw, I believe that the median age that you found with the group was 12 months across the board. Is that right? For the palate closure? And I thought that's what I saw. And I could
It
be
was
wrong.
12 for the kids without Piroband sequence. And then for the kids with Piroband sequence, it was 13 and a half months.
So that was interesting to me because I know when I first started, the surgeon that I work with, everybody had their palate repair at 12 months. That was it. And there were lots of conversations between him and our SLP about doing it earlier. And so over the years, I found that we were doing it at around 10 months. And so, it made me, think about, why. And I think part of it was that the surgeon that I worked with was trained by a surgeon who did it in that way. And so I think that, just in terms of a consensus, there's so many people involved with this doing things in different ways. But I think you're right that in terms of the nutritional part of it, I think that's something that everyone can agree on, that early growth. And I wonder, is that something that in any future studies that your group might be looking at? And I know for sure, it's something that to me should be and is a mission of our organization, is to try to help to really optimize, the lives of our kids. When I think about these kids that early on, and sometimes they're not even in our hands at that point, and I think that's part of the problem. So I wonder, anything, Kari or Jessica, or anything future that's, that might be looking at that, or also advice for anyone who's listening, who's on a team that gets patients from community hospitals, or, that are just really struggling because it looks, that maybe there's a lack of understanding about how to approach feeding with them before they even get to a team. Okay, you're all three muted, so I'm going to unmute one of you.
I can start sharing my thoughts, and then I'll pass it off to Jessica or Greg. With respect,
I know it's a big ask,
Yeah.
it's a big deal, but I just know when I'm at the meetings and I'm talking to other nurse practitioners or other coordinators, SLP feeding people, one of our big things is, they come to us and, why haven't we been able to get the message out everywhere about, how we can help these kids earlier on? Kari?
I think one of the challenges is, feeding is a difficult thing to study in these medically complex children at such a young age, when the priority is getting them to improve their nutritional intake. And also collecting these data at single centers or single institutions can be really challenging as well. And so that's why we leverage the Cleft Outcomes Research Network in order to answer this question using many different cleft palate teams. And when you're looking at such a low incidence condition such as Piroband, you really need a larger sample size, which the CORNET study afforded us because of the larger network. And so we were able to answer this question with a much larger sample size than if we were looking at just one or two hospitals. And so trying to answer those questions using a network, I think, or using multi-sites and collaborating with providers at different institutions, I really think is the way of the future. And so as we improve our prospective research in that area, hopefully that also helps improve the messaging that we're able to get out about our findings, and that translates into the care being provided in communities as well.
Can we just talk for a sec about the finding regarding the families of the Hispanic background? And I mean, obviously, that is a big hurdle for many teams in terms of groups of patients or particular families that are challenged. And I wonder if you could just speak to that a little bit. And, and I know every team, is so challenged with this. And, any thoughts about, what you, and I know that, I think you mentioned looking at that in the future in terms of how can we deal with that challenge, that finding, which I was also not surprised to see that, the challenges that some of these families have with compliance or getting to a team from the get-go, so I'm just wondering, how, what might you be studying for the future, or any thoughts that you have for other teams that are facing this same challenge with the whole, the social determinants of health, which is such a big issue right now. And I'm seeing a lot of papers, and I'm sure you are too, coming out in the journals about this. So I think we're really not only recognizing it, but we're at the point, what can we really do about it? All right, all three of you are muted, so
I'll speak to it briefly. I think in clinic, we see, and especially being in Arizona, we have a lot of families and patients of Hispanic ethnicity. And one thing those families do extremely well, those families feed their babies and do a great job with that. And, our finding was related to timing of palate repair. And I think that gave us a really nice opportunity to look into research in other areas of medicine outside of just cleft and see what's going on in some of those other areas with this patient population. And I do think in some other areas, they talk about language barriers. Are families getting written education in their language? Are there barriers, like you said, to getting to appointments that are then subsequently delaying palate repair because they maybe missed an appointment? And so one of the things we suggest in our paper is when teams are able to really leveraging social work. And I think our team has been extremely fortunate that we have a team social worker. And so actually, after we found this finding for this paper, our team keeps an outcomes thing. I was like, are we doing a good job? Like, what do we need to be doing on the locally? And I do think that our social worker has helped tremendously for caring for these families. So I agree. It's not just a concern in our area, but a concern in medicine that I think we need to be working on to make sure we're delivering the best care we can to these kids and kind of breaking down some of these barriers.
I think it's interesting. It would be interesting to look if you looked at teams around the country to see which team has a dedicated full-time or even dedicated half-time social worker, because that's another theme I've seen over the years and I wonder if you would see a correlation between ability of families to comply with treatment and have, for example, have their palate repair on time if they're working with a group that has a full-time or part-time social worker. Because many people that I have spoken to over the years at meetings share a social worker, or maybe just one inpatient at the hospital that helped them sometimes. And I think that's a challenge for many teams still, and I think it also comes down to funding for them. There's always issues like that. But I know for sure, when I first started, I didn't have my own full-time social worker, and I had to really push and fight for that because there were so many needs that you need someone with that expertise who can really focus on helping families. So I agree that, having that social work support for these families from the get-go is just incredibly important. And having that social worker really identify from the very beginning, meeting every single family and just making sure that we know that we can, red flag any families that maybe aren't going to be able or have so many challenges that they might not be able to follow the plan. So, lots of really good things came out of your paper. And again, even though the the findings weren't surprising. I think it really, for me, for sure, and I'm sure for others who read this in all different specialties, because, look, we have nursing, we have surgery, ENT, and speech and feeding on this call. I mean, we are all involved in this. It's not isolated to to one person on the team, getting that child to the OR table. It's really a team effort. And so I wonder, if before we finish, if any of you have any other thoughts, anything you wanted to, I know one thing I wanted to ask you. What advice do you have for teams? I mean, you had this great effort with all of these teams to produce this work, which is amazing. What if someone wants to do something multi-center and they've never done it before and they want to reach out? Any thoughts about, because I mean, everybody talks about, well, the best works are prospective, multi-center studies, but I don't think I have to tell you how challenging that can be. Any thoughts on that, Greg?
I think the study coordinators, in particular Kathy and Kari, can tell you that this is a monumental undertaking, and Kathy and her team have done an amazing job in putting this together, gathering the pilot data, applying for funding, receiving that funding. And then once that happened, the hard part started. We thought the hard part was getting the study off the ground and getting the funding. But I think the rest of the team can tell you that that's when the work really started, and the work continues with this study. So, I think more than anything, it might be, if you're interested in this type of study, get involved in utilizing some of the data that other studies have obtained. All of the participating institutions have the opportunity to come up with projects and request the data. And so you can get multi-institutional collaborative data without doing your own study. And, I would suggest, if you were one of the participating institutions in this study, think about a question that this data that we have, this trove of data that we have, might be able to answer without doing your own study. And the numbers in this study provide power to answer, I think, a lot of questions that we're not even aware we need to ask yet.
Right. Kari?
I mean, as Greg alluded to, collecting prospective data is expensive and it requires often external funding to be able to do that. And so if somebody's starting out in research and doesn't have access to those types of resources yet, I think that's when we often see more retrospective studies being collected. There's also opportunities for secondary data analysis of data sets like CORNET that contain multi-site data. But something that I'd like to put a plug in for that Dr. Sarah Kincher presented at the ACPA annual meeting at pre-conference, and she also published a tutorial in CPCJ that came out online, I think in February, was how to mitigate bias in conducting retrospective craniofacial outcomes research. And so I think for somebody starting out, that's a really great tutorial written from an epidemiologist perspective about how to reduce bias when conducting those retrospective studies. So if somebody's interested in starting out, I'd say that's a great resource to look into.
Oh, that's great. I'm glad that you recommended that tutorial. Okay, Jessica, any last thoughts about this before I sign out with all of you? This has been great.
I don't have any other thoughts, but I know we've focused on the paper, but I really think, to echo what Greg and Kari have said, like, this is not possible without the tireless work of Dr. Kathy Chapman. Like, she is an outstanding researcher. She's has been a wonderful mentor to myself and Kari, and just the time and dedication she put into this study. Just can't go without saying thank you to Kathy.
Yeah, she's truly amazing. She's really, she has just brought so much knowledge, and just, she Just amazing. I agree with you. So let me for the listeners, once again, this is a great paper that everyone on any cleft team that works with kids, especially kids with Robin sequence. This came out online first on March 14th. It's feeding management and palate repair timing in infants with cleft palate with and without Pierre-Robin sequence, a multi-site study, and yes, truly multi-site. And the authors are Jessica Williams, Kari Lean, Richard Kirchner, Gregory Allen, Kathy Chapman, and on behalf of the Cleft Outcomes Research Network Cornet Consortium. This is, I think this is a paper that, really is something that everyone should read. I think it will really help us to maximize and optimize the care of these kids. So I want to thank you all for taking the time to join me for this. This was terrific. And thanks so much. Take care, everyone.